Hello everyone and welcome back to Biomed Prep. If you're preparing for your orthopedic OSCEs, trauma exams, or board assessments, this video is going to be extremely high yield. Today we're going through multiple orthopedic stations in a structured exam format, exactly how you might encounter them in a clinical exam. I'll first present the station questions just like the examiner would. When you see a slide that contains only questions, pause the video and try to answer them yourself before we go through the model answers together. Active recall is one of the most powerful ways to learn. Before we begin, please make sure to like this video, subscribe to Biomed Prep, and share it with your colleagues. It really helps the channel grow and allows me to continue producing free medical education content. And just a reminder, this material is for educational purposes only and should not replace clinical judgment or specialist consultation. Let's get started. You are shown an X-ray of an elbow injury. The questions are: what type of injury is this? What nerve is commonly injured? What test confirms injury to this nerve? What is a pink pulseless hand and a pale pulseless hand? What are the complications of supracondylar fractures? What is the brachialis sign? Why are fractures common in this region? Pause the video now and try to answer these before we go through them together. What type of injury is this? This is a supracondylar fracture of the distal humerus, specifically an extension type injury, Gartland type 3. Extension-type supracondylar fractures account for about 95% of cases and typically occur after a fall onto an outstretched hand, FOOSH. In Gartland type 3, the fracture is completely displaced. There is no cortical contact. It is unstable and often requires surgical fixation. This is one of the most common elbow fractures in children. What nerve is commonly injured? The most commonly injured nerve is the anterior interosseous nerve, AIN, which is a branch of the median nerve. The AIN is a pure motor nerve, so there is no sensory loss. What test confirms injury? Ask the patient to make the OK sign. In AIN palsy, the patient cannot flex the distal phalanx of the thumb, cannot flex the distal interphalangeal joint of the index finger. Instead of a circle, they make a flattened pinch. This is a classic OSCE favorite. In supracondylar fractures, several nerves may be injured depending on the direction of displacement. The most commonly injured nerve in extension-type fractures is the anterior interosseous nerve, which is a branch of the median nerve. Injury to this nerve causes weakness of flexion at the distal phalanx of the thumb and index finger. This is tested by asking the patient to make an OK sign. Instead of forming a circular O, the patient forms a flattened pinch due to inability to flex the distal interphalangeal joints. The median nerve itself may also be injured, leading to sensory loss over the lateral 3.5 digits. The radial nerve may be injured, particularly with posteromedial displacement. Radial nerve injury presents with wrist drop and sensory loss over the dorsum of the hand. The ulnar nerve is more commonly injured in flexion-type supracondylar fractures. It presents with weakness of intrinsic hand muscles and sensory loss over the medial 1.5 digits. In every case, a full neurovascular examination must be performed and documented before and after reduction. Complications of supracondylar fractures. A very good way to remember complications is the ABCDE mnemonic. A. Anterior interosseous nerve injury. B. Brachial artery injury. C. Compartment syndrome. D. Deformity. Cubitus varus, gunstock deformity. E. Elbow stiffness. Now let's structure this by timing. Immediate. Brachial artery injury may lead to Volkmann's ischemia, median nerve injury. Early. Compartment syndrome of the volar compartment. Volkmann's ischemic contracture, muscle necrosis of flexor compartment. Late. Malunion. Cubitus varus deformity. Myositis ossificans, persistent elbow stiffness. One of the most important complications to assess is vascular injury to the brachial artery. A pink pulseless hand refers to a hand that is warm and well perfused but lacks a palpable radial pulse. This occurs due to arterial spasm or compression with collateral circulation still intact. It requires urgent reduction and close monitoring. A pale pulseless hand, however, is cold, pale, and poorly perfused. Capillary refill is delayed or absent. This indicates true arterial compromise and is a surgical emergency requiring immediate reduction and possible vascular exploration. Why are fractures common in this region? In children, the distal humerus is thin. It is undergoing rapid remodeling. The supracondylar area is structurally weak during a FOOSH injury. The olecranon acts as a fulcrum. Hyperextension force snaps the thin supracondylar bone. That biomechanical weakness explains the frequency in pediatrics. The brachialis sign refers to ecchymosis and puckering of skin over the anterior elbow, suggesting the proximal fragment has pierced through brachialis muscle. It indicates severe displacement and higher risk of neurovascular injury. You are shown a severely injured lower limb. What is your diagnosis? What is the classification? What are the three main criteria of the classification? What is immediate management on presentation? Pause the video here and try to answer. Diagnosis. This is an open tibial fracture. Tibia is the most commonly fractured long bone and frequently open due to minimal soft tissue coverage. Classification. This is classified using the Gustilo-Anderson classification, in this case type IIIB. Type IIIB involves extensive soft tissue damage, periosteal stripping, requires flap coverage. Classification is based on wound size, degree of contamination, soft tissue injury and coverage, immediate management, follow ATLS protocol. And always remember, life before limb, primary survey, airway, breathing, circulation, then IV antibiotics immediately, tetanus prophylaxis, sterile dressing, splinting, urgent orthopedic referral for surgical debridement. Early antibiotics significantly reduce infection risk. A 26-year-old male involved in an RTA sustained a dashboard injury. The limb is shortened, flexed, adducted, and internally rotated. What is your full diagnosis? List 3 management methods. Mention 6 complications: too early, too intermediate, too late. Pause here and answer before continuing. Full diagnosis: posterior dislocation of the right hip with fracture of the posterior acetabulum. Classic dashboard injury, femur driven posteriorly, limb shortened, flexed, internally rotated. This is an orthopedic emergency. Reduction should occur within 6 hours to reduce risk of avascular necrosis. Management methods. Closed reduction techniques include Alice maneuver, Stimson method, Captain Morgan technique, East Baltimore lift, Howard maneuver. Modified Alice is commonly used. If closed reduction fails, right pointing arrow open reduction. Complications. Early, sciatic nerve injury, especially perineal division, vascular injury, e.g., gluteal artery. Intermediate, unreduced dislocation, associated femoral shaft fracture. Late, osteonecrosis of femoral head, myositis ossificans, post-traumatic arthritis. Avascular necrosis risk increases dramatically if reduction is delayed. Diagnosis: bilateral severe osteoarthritis. What radiological features support this? What is the treatment? What lines are drawn when assessing a pelvic X-ray? Pause and attempt. In this station, the diagnosis is bilateral severe osteoarthritis. Radiological features include loss of joint space, osteophyte formation, subchondral sclerosis, and subchondral cysts. These features can be remembered using the acronym LOSS. Osteoarthritis is a degenerative joint disease characterized by progressive cartilage loss, mechanical joint pain, stiffness that worsens with activity, and reduced range of motion. Management begins conservatively with weight loss, physiotherapy, walking aids, NSAIDs, and intra-articular corticosteroid injections. If conservative management fails, surgical intervention may be required, including osteotomy or total joint replacement. Total hip arthroplasty is indicated in patients with severe pain and functional limitation that does not respond to medical therapy. Important lines: iliopectineal line, ilioischial line, Shenton's line, anterior acetabular rim, posterior acetabular rim, acetabular dome, teardrop, sacral arcuate line, Klein line, Hilgenreiner line, Perkin line. Examiners love asking these. Now on to Station 4. Mention 2 orthopedics indications for the treatment above. Mention 2 non-orthopedics indications for the treatment above. How is functionality of the above treatment assessed? What age group and why isn't it used in older patients? The treatment being demonstrated is gallows traction. Gallows traction is a form of skin traction used primarily in pediatric patients for the management of femoral shaft fractures. It is most commonly used in children under the age of 2 years, or in children weighing less than approximately 12 to 15 kilograms. Gallows traction involves suspending both lower limbs vertically, with the hips flexed to approximately 90 degrees. The legs are wrapped in skin traction bandages, and the child's buttocks are lifted slightly off the bed. The child's own body weight provides the countertraction needed to align the fractured femur. This method works well in very young children because their bones heal rapidly, they have excellent remodeling capacity, and their body weight is light enough for safe suspension using skin traction. The main orthopedic indication for gallows traction is an isolated femoral shaft fracture in a child under 2 years of age. It is particularly useful in closed fractures without significant soft tissue injury. Another indication may include stable femoral fractures in very small infants where operative fixation is not necessary. Gallows traction is not used in older children primarily because of weight limitations. As children grow heavier, the amount of traction required increases, and skin traction becomes unsafe due to the risk of skin breakdown and neurovascular compromise. Additionally, older children are less tolerant of prolonged immobilization in this position, and they are more commonly managed with surgical fixation. How do you assess whether gallows traction is functioning correctly? The answer is the hip sweep test. In this test, you gently attempt to pass your hand beneath the child's buttocks. The buttocks should be slightly elevated, and just clear off the bed. This indicates that adequate traction is being applied, and that the child's body weight is acting as counter-traction. If the buttocks are resting flat on the bed, traction is insufficient. If they are excessively elevated, there may be over-traction, which increases the risk of complications. As with all traction methods, there are potential complications. These include skin breakdown from the adhesive traction, pressure sores, neurovascular compromise, and compartment syndrome if not monitored properly. Frequent neurovascular assessment is essential. Capillary refill, distal pulses, color, temperature, and movement must be checked regularly.